video. So this video is going to cover antidepressants. So we sort of started off with the antipsychotics and talking about sort of why medications are prescribed in terms of the pharmacotherapy model. So in order to sort of understand why these medications were designed and how they work, it may be of interest for me to introduce. Some of you probably already know this, but introduce sort of the biogenic amine theory about depression. That way you can kind of understand what we're doing when prescribing antidepressants. And then I'll sort of speak to a few situations where, much like I did in the antipsychotic video, what symptoms or when you might prescribe one antidepressant over the other. So to begin this discussion, depression results from an amine concentration that's too low to activate sufficient receptors. All right. So what I mean by amines, that's norepinephrine, serotonin, dopamine, and epinephrine. Even though epinephrine's not one that we really directly deal with, but this is all part of the sort of biochemical process breakdown from tryptamine. So that's what's going to start this whole process. So the assumption is that amines are too low. So every one of the categories of antidepressants are designed to increase those in order to satisfy the biogenic amines. So you've got SSRIs, you've got SRNIs, you've got TCAs, and you've got MAOIs. And then you've got the actions of lithium. Lithium has been recently utilized in a depressive category. We'll probably speak more to it whenever I'm talking about bipolar, but just know that if you do see lithium in the clinical setting, more often than not it's going to be for bipolar, but it's possible this person may have treatment-resistant depression, and that's what lithium is on board with. The best way for me to sort of describe antidepressants in a way that you can understand it in terms of their overall activity is from what we call antidepressant-mediated genetic modification. Antidepressants, even though that when you first take one, whatever neurochemical of interest is being increased, so for instance SSRI, serotonin, that happens immediately. However, it takes about anywhere from 2 to 4, 3 to 6 weeks for it to actually have its full effect. So, you might wonder sort of why that is. Just to give you an understanding of that, a quick recap for the sort of second messenger theory, genetic theory of why antidepressants take a while to work, is a G protein attaches to a receptor that is changed due to that antidepressant. So if a person is depressed, then they're going to have a G protein genetically sort of designed to function within that receptor. So what this does is actually start to change those receptors, start to change the network, and start to change the sort of DNA sequencing through a process. So the G protein attaches to the receptor. G protein then activates an enzyme like adenyl cyclase. That enzyme activates a second messenger system, which in the case of antidepressants is going to be ATP catalyzed to CAMP. CAMP activates protein kinase. Protein kinase activates the inactive transcription factor, now the active transcription factor direction, genetic output, receptors, enzyme. And so what that means is that when you first take an antidepressant, it's not going to change things immediately. All you're doing is providing the neurochemical of interest, so you're recepting on it. But over time, there's actually changes in the DNA sequencing to actually change the way that it codes for receptors and codes for those neurochemicals. So that's why it takes a long time, because you're actually altering sort of DNA sequencing versus just boosting effects. So for things like benzodiazepines, when you take an Ativan or something for anxiety, that's an immediate effect, because the principles behind it are much different. Though if you do take benzodiazepines over time, it will start to change sort of the DNA and receptor sequencing, but it's much different, and it doesn't involve in the same capacity the second messenger system. One thing to keep in mind in terms of serotonin and sort of thinking about side effects is what's unique about serotonin versus your dopamines, your norepinephrines, etc., is where it exists predominantly. So dopamine, norepinephrine, we think of them as existing in the brain, and serotonin exists in the brain, but it actually exists 95% in the gut. So when we think about actually prescribing SSRIs, SRNIs, then it makes sense that the side effects are going to be primarily in the GI system first. So that's why. So some of the side effects to SSRIs are going to be nausea, loose stools, diarrhea, weight loss or weight gain. The agonism of the 5-HT 5-HT3 serotonin receptor is said to be what is primarily responsible for those GI symptoms. So to give you sort of a reference to your primary care teaching, Zofran, which we know is used for nausea and things like that, actually antagonizes that exact same receptor, the 5-HT3. Another side effect, and the GI stuff is one of the main reasons for non-compliancy, along with sexual side effects. And the sexual side effects to serotonin are because with serotonin you increase the prolactin, and sort of in the same way with the antipsychotics, you're going to get an increase in sort of hormonal disruption through gonadotropin hormones, etc., etc. But they can decrease libido, they can cause impotence, delay ejaculation, and decrease orgasm, and that's caused by the agonism of the 5-HT2 receptor. So to give you another primary care reference, the medication sildenafil or Viagra blocks serotonin to this receptor, which is part of why it helps men with sexual problems and can be used with people that are taking SSRIs to sort of counter-effect those sexual problems. Interestingly, Viagra has also been demonstrated to be effective in women who suffer from anorgasmia from SSRIs as well. So it's not all that uncommon to see a woman on sildenafil or Viagra. You may think that's odd, but check to see if she's on an SSRI, because that's the most likely probably explanation. There's another medication that you may use or have seen before called cyproheptadine, which is an appetite stimulant. What it actually does is blocks the 5-HT2 receptor. So some people will use cyproheptadine to actually counteract the sexual side effects that are mitigated by that receptor. But the cautionary is that cyproheptadine also blocks other serotonin receptors as well. So if someone is on there, or if it requires that you need to add cyproheptadine for appetite stimulation purposes, you might need to increase the SSRI, or you may have someone that a primary care provider has put on cyproheptadine that may come to you, or someone else says, I feel kind of depressed, I feel worse, I don't feel like the medication's working anymore. Well, in that case, again, you may want to look at either discontinuing the cyproheptadine, depending on the appetite situation and why it was prescribed, or again, looking to see if you need to increase, or maybe even switch it to a different category of antidepressants that doesn't primarily affect serotonin. Now, we talk about these side effects in a way that is negative, but in a lot of ways, such as the case with medicine in general, is we use these side effects sometimes to our advantage. So, for instance, if you have someone that comes to your primary care office and they're talking about that they have a pre-ejaculation, sometimes you can actually prescribe low dose of SSRI because it actually will sort of delay the ejaculation or delay the orgasm. So if you see someone that's on a low dose SSRI, don't just automatically assume that they're depressed. It could be that it's being used to help out with a sexual problem non-related to the depression. And then further in prisons, when you have people that have inmates that have hypersexuality, have sexual predators or sexual impulse control problems, high doses of antidepressants and often antipsychotics are prescribed, not necessarily for psychosis or depressive purposes, but because it actually will suppress their sexual desires. So that's an ideal. So you'll see those things if you work in a prison. So for the GI and sexual side effects, because they're the two primary reasons why you may have compliance issues with people in SSRIs, it's important, A, to talk about those things, and then B, to have sort of strategies if that is in fact the case. The best approach initially is sort of the wait-and-see approach. Within about a week or two, about 50% of the GI symptoms tend to resign, and about 35 to 40% of the sexual side effects tend to resolve. If not, you may need to reduce the SSRI dosage, or you may want to augment an agent that we're going to talk about later on called bupropion, which actually increases dopamine, and so you can kind of counteract the effects from the prolactin increase, which we talked about in the antipsychotic chapter, inverse relationship between dopamine and prolactin. You increase dopamine, you increase testosterone, you increase the pleasure sort of principle, if you will. You can also use buspirone, which is a selective serotonin agonist, and it actually will counteract some of the serotonergic effects on the 5-HT2 that we had talked about earlier. Or you may have to, again, switch over to a different SSRI, like an SRNI that has less sexual side effects. Or you can actually prescribe an SSRI like an escitalopram that has a low incidence of sexual dysfunction comparative to things like Paxil or paroxetine, which has the highest incidence of sexual dysfunction. Other side effects from the SSRIs that are of interest is sometimes excessive sweating, and that's really a deregulation between dopamine and serotonin in the hypothalamus, and then CNS symptoms of headache, dizziness, tremors, anxiety, and insomnia. Sort of counterintuitive that we use SSRIs sometimes for anxiety, and it can also produce anxiety symptoms, but it does happen from time to time, and if that's the case, they're probably not going to take the medication anyway, so you may want to think about a different category of medications altogether. The other thing I want to talk about briefly that the PowerPoints in the book actually talks about is the black box warning that's on SSRIs in terms of suicidal thoughts or behavior that tends to affect 18 to 24-year-olds, which is actually what's specific to the black box warning. It typically happens within the first 2 weeks of initiating antidepressant. Now, there's some people that say this is a side effect. There's some people that say that the medication is actually working. I tend to sort of agree with the latter. But what you do need to know about this is that the first 2 weeks are probably going to be the most dangerous for the person that you're treating. And if you think about depression in sort of its extreme form, these are individuals that they don't have energy to get out of bed, they don't have energy to get dressed in the morning. Even thinking through the process of moving the covers back, leaning up, moving their body to the side of the bed, putting on shoes is exhausting. And for us, we do this automatically, but for them, because of the cognitive sort of impairments that go along with the depression, this is a very exhausting thing. So you may have someone that is barely able to even think through sort of the activities of suicide, planning out their sort of proverbial sort of end of life decisions, money allocations, who's going to get what, sort of a makeshift will, which a lot of times people that commit suicide do sort of have these planning processes. They can't think through that, but what happens when you start to actually provide an SSRI is you begin to awaken sort of their energy levels, you start to activate them, and then they become where the depression still exists, because as we talked about with the genetic modification, it takes time. Now they're able to actually think through this process, but the depression still exists. So it's a very difficult situation for them. I always recommend when you first initiate SSRI, you really want to monitor them for probably a month to a month and a half. If the depression is fairly severe, you probably want to see them at least every 2 weeks, if not sooner, depending on if they had pre-existing suicidal ideation. But that is something to keep in mind and sort of to watch for. Other important issues with SSRIs that I think are important, the book and the PowerPoint sort of allude to, is the serotonin syndrome. Usually this is caused by combining multiple antidepressants. You can see it in other ways, though. Lithium can increase serotonin, tramadol can increase serotonin, amphetamines can increase serotonin. So you may see serotonin syndrome with those combinations. So be very careful whenever you're co-prescribing or you see, because it's not restricted to just psychotropics. Like I said, you got tramadol that can increase these and put you at risk for serotonin syndrome. And then, of course, combining your TCAs and MAOIs can also produce that as well. Signs and symptoms of that's hypothermia, rigidity, cognitive impairments, and autonomic symptoms. The other one is apathy syndrome. This happens with some people that take SSRIs. The media has been particularly attentive to this, and that they've made a lot of associations with homicidal acts in people that are on antidepressants, that this general condition is they lose interest in life around them, and sometimes it causes a disconnect between themselves and reality. And the extreme forms of this, I guess, could result in homicidal ideation, but that's not typically the normal course. But just know if someone is talking about how instead of them going in a positive direction with their depression, they actually talk about sort of a loosening of connection to reality and sort of a dissociation of sorts. I want to consider switching over to a different medication, or perhaps inpatient, depending on the severity of the comments. There's also withdrawal syndrome. This can happen when you're discontinuing SSRIs, so you want to make sure that you tell an individual if they're having negative